The fourth case, a 66-year-old man who 20 years ago had surgery for reflux and an ulcer in the stomach, I guess. In September, he had a C5M5 Barrett's esophagus diagnosed with no visible lesions, but one of the biopsies showed high-grade dysplasia. This was confirmed by a second pathologist and discussed on a multidisciplinary meeting. Pardon me?
We got kicked out of the Zoom.
You're in the Zoom, don't worry.
Well, we don't see you.
Well, something.
But hold on, just pause. Let's restart this whole thing. Like, if you cannot see in the seminar, I need to open, not on my computer, on the mouse of the main screen, you need to open the VLC stream and you will see us. We'll have to do the whole thing again.
Okay.
Based on all the learning you've picked up today.
Yeah, so we also know that the high-grade dysplasia specimen was coming from the top. There were 3 biopsies taken from 40, 37, and 35. And yeah, at the top of the maximal extent. And yeah, we are just about 35, where the biopsy was described as was taken.
Mm-hmm.
And in this region is probably something or an invisible lesion. So this is, when I pass this first part, I don't see anything, but a little bit distal. On the 12 o'clock, there might be something.
Something's
already
jumping out.
Yeah.
Okay, let's keep going.
Yeah, I will keep going distally. And with white light, constantly on air.
Now, you're going to focus your attention, as I think you're doing, at the top, where we know, well, we think we know. I mean, you never know, Oh, you never know. Watch the cap. Eh? Be careful with the cap because you don't want to lose that vision that you have. So something, pause it, please. Something's jumping out. Already there's loss of acetyl whitening in the 12 o'clock. Just check the rest quickly and come back to this time efficiently. Check the rest, the whole rest of the Barrett's. That's you and your cap, unfortunately, down there. That is cap trauma to the Barrett. You see it's very different from the other appearance. It's very multifocal. Okay, fine. Come back to the main event. Take a photo. Okay, that's a great photo. It tells you there's nothing wrong with the Barrett's. Keep coming back. Keep coming back into this zone of concern. Right. So we for sure have a early loss of acetyl whitening here. Yep. You do what you would normally do. So we have this zone. This patient is needing some sort of treatment of this because we have identified a visible lesion, we think, within a Barrett's esophagus, long segment. We've had a biopsy of high-grade dysplasia. Yeah. What do you think? Are we going to do captivator EMR of this, or are we going to biopsy this again? Are we going to do ESD? What are we going to do?
Well, if there is a visible lesion, we are to the resection site. If it's invisible, we are on the...
Well, but it's not invisible. It's visible, right?
There is a visible thing.
Okay.
So deciding on whether doing an EMR or an ESD is probably mainly depending on 2 things, whether we think it's invasive and the size.
So do you think it's invasive?
I do not think it's invasive.
Okay, I also do not think. Again, a bit outside the scope of this course, but I think this is flat dysplasia in Barrett's. It's relatively localized and it's not terribly disordered in my view. So these are the things which I'm thinking. What do we think, Lobke? What do you also think, John?
I was thinking, would you, so if you say it's flat, you can actually do RFA, but I feel I have a bit of an impression that it's not flat. As you look now to this picture at the right-hand side, you can see a completely flat Barrett's, while on the left, it's a little bit like uneven surface, and probably RFA would work, but I wonder if it's not better to do a resection here. If we're talking about
I agree with half of what you said. I agree with the concept that if it's that this is maybe not flat, but I don't agree with the fact I'm never doing RFA to something visible, even if it's flat. I'm always doing resection. That's
Yeah,
my
okay.
practice. Whatever. Okay, back to real life. What are we going to do with this? So if you're in a peripheral center and you find this finding, well, that probably wouldn't happen because we've already seen the story about what's happened. Random biopsy shows high grade. We're in a referral center. What are we going to do? John, got a view?
Yeah, I mean, firstly, it was a good spot. Secondly, I think I'm all about contours and color contrast, David. So when you look at the contours rather, as Lob says, there is a little protuberant area. So it's not when you stand back and get the overview, which I thought was a really good way of doing this. There's an abnormality as you've already highlighted in that area. Secondly, there's no need to rebiopsy it and bring it back. It's pointless. You've already got high-grade dysplasia, and you run the risk of sampling error. So for me, the critical thing is to demarcate the extent of the lesion, and the easiest thing to do this would be for cap band resection. You know, single piece or multi-piece, depending on the size. I don't think you can do nothing, and I wouldn't necessarily biopsy and bring back. I don't see there's any benefit to that.